Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we are going to talk to one of my very, very favorite people on the planet, Dr. Michael Hogan, who's written an article with Matt Goldman on new opportunities to improve mental health crisis systems. So this focus on crisis care is really important. And I want to make one other point, that this article is part of the Think Bigger, Do Good. I love that. The Think Bigger, Do Good series. Commissioned, and it's commissioned by a number of foundations, and out of respect to them, I'm going to read all of the names of the foundations. Let's just take a minute. The Thomas Scattergood Behavioral Health Foundation, PEGS Foundation, the Patrick P. Lee Foundation, and the Peter and Elizabeth Tower Foundation. And they have commissioned this wonderful series on Think Bigger, Do Good. And we are so pleased to have Mike with us today.
Should be a great conversation. So we're very lucky to have Dr. Mike Hogan, who is the former New York State Mental Health Commissioner, on to talk with us about his new article, New Opportunities to Improve Mental Health Crisis Systems, which he wrote with former Pages to Practice guest Matt Goldman. So Dr. Hogan, thank you so much for joining us.
It's great to be with you.
So, as usual, we start off these interviews by asking folks about how they got interested in this particular topic. In this case, it would be about crisis services. And I think, a lot of our listeners are familiar with some of your work and your career, but it also might be helpful to hear about how your career path led you to be writing this particular article at this particular time.
Well, it's been quite a journey. In fact, interest in crisis services for me began with my first leadership role in mental health, which was an embarrassingly long time ago in Massachusetts, trying to lead the Western Massachusetts mental health system through a federal court consent decree that, in a sense, was a precursor of Olmstead. And it required the development of community services to essentially substantially replace the Northampton State Hospital. And so a key part of those services, a lot of them emphasized longer term supports to bring long stay patients out of the hospital, but crisis services to provide alternatives for acute care were a key a part of that. And so it was a real learning process because there wasn't a tremendous amount known or going on in that regard at that time. And so we developed crisis services in each area of Western Massachusetts way back about 1980. And so learned their importance and effectiveness. And then I went from Massachusetts to Connecticut as deputy commissioner under Audrey Worrell, and then as commissioner, and we made some investments in crisis services at the time. And one of the people who urged us to do that was Dr. Len Stein, who, of course, we think of as the developer and researcher of assertive community treatment, which has had a profound effect on continuing care for people with serious mental illness. But Len told us that in developing community services, crisis services ought to be the first priority because they touch so many people. They led to use of hospitals that would otherwise be unnecessary. And they occurred to people when they were, in a sense, at their worst and needed the best we had to offer. And that's a
great sort of story that Len Stein was of great influence on you. That's great.
I'd like to call him a mentor, but I'm not sure. I certainly learned enough from him to use that term, but I'm not sure that he would think that he gave enough. But I think that would be wrong. But anyway, so we developed some crisis services in Connecticut in the 80s, And then I went on to, roles, 16 years as Commissioner of Mental Health in Ohio, and then back home to New York. And in those assignments, that crisis care wasn't really an urgent priority because other things demanded attention in the system. And I think in trying to lead organizations, like in sports, you sometimes have to take what the defense will give you, and there are things that have to be done. But since leaving the Office of Mental Health in 2012, I've had the luxury of working as a part-time consultant on issues that I wanted to, and they generally had the requirements of being areas where there was a gap between what we know and what we do, and where that gap was consequential in terms of public health, and where I could do a little bit that was helpful. And so priorities have been working on suicide care, which has begun to improve significantly, but where we still have a long way to go. A little bit of work to support Bob Drake and his colleagues' efforts to develop supported employment. And then finally, crisis care, which is just an incredible patchwork across the United States.
So maybe we could talk a little bit about that patchwork. I mean, the article is very interesting because I think there's kind of two aspects of it. One is about crisis, and the other is about policy making. And maybe we could start with crisis. And by way of introduction, maybe you can walk us through how, in your mind, an ideal crisis system would be operating right now, and then like what aspects of that system are we currently missing?
Yes, thanks. I think that's a good way to approach it. I'd cite two pieces or places or publications for the question of what crisis services should look like. My work on this really got accelerated with a task force of the National Action Alliance for Suicide Prevention, which was co-chaired with David Covington. And we were tasked by the National Action Alliance, which is a public-private advisory and advocacy group that is, the effort is sustained by SAMHSA, but operates independent of SAMHSA to try to guide and advocate for suicide prevention. And so the Action Alliance asked or allowed us, I don't know which, to take on crisis services as a project. And so we pulled together a working group of about 30 people involved in crisis care around the country, and produced a report for the National Action Alliance. And so that report is on their website with a lot of other materials on crisis care at a website that people can access just by searching for Crisis Now. And David and his colleagues have put up a website with the support of NASHBID, the State Mental Health Directors Group. And Brian Hepburn has been another strong leader of this effort. But the Action Alliance group developed I guess what I would call a best practices framework for crisis care with three key elements. And the first of those elements is what we've started to call now care traffic control. Care traffic control is a statewide or regional technology-enabled crisis center that has the capacity to handle telephonic crisis intervention. Ideally, it should be a call center for the National Suicide Prevention Hotline. So a lot of the calls that people make in crisis can be resolved over the telephone. This is actually that as a mental health professional, I was a little bit naive when it came to the power of crisis lines. Many people who call a crisis line are in a mild or moderate degree of psychological distress and need somebody to talk to. But about 25% of the people that call the suicide prevention Lifeline are suicidal at the time of their call. And about 75% of them, that is, of actively suicidal callers, by the end of the call, report that they are essentially okay and able to manage the situation. So the conversation with a skilled and empathic person is a very powerful thing. So that's the first element of the crisis system. But the crisis call center should be embedded in a hub that has the ability to use, for example, geomapping and Uber or Amazon style technology to identify where people are, to identify acute care resources that are available in their community, to deploy mobile crisis teams if they're available, and to actively coordinate this network of acute care. So the crisis call center or care traffic control center is the first element. The second key element I've mentioned, and that's mobile crisis teams. Often a master's level clinician and a trained peer, or sometimes a non-peer paraprofessional, but the trained peer specialist and the master's level mental health professional are probably the most common configuration, and they can be dispatched to go to where the person is, hopefully to meet them before they get to an emergency department, and resolve the situation by sticking with the person until the situation is resolved. And the best practicing mobile crisis programs are able to resolve 3/4 or more of their crisis contacts in the visit. And then the third level of crisis care, or the third element of the model, is crisis facilities, which are quite divergent, but I'll just mention a couple that are exemplars. One is that a surprising number of people who are in mental health crisis, if they have an opportunity to meet with a mobile team, for example, can have the urgency of the situation reduced enough so that they feel okay, just so long as they can get in to see a therapist or to get a medication refill in the next 24 hours. And so open and accessible outpatient care is a critical component of a good crisis system. And given pressures on outpatient care, all too frequently, outpatient slots are just pre-scheduled and taken up by repeat customers, and open clinic access isn't really available, but it's really invaluable for a portion of the people who are having a crisis. And then the next highest level of acuity, I guess, if you could describe it that way, would be crisis residential facilities. And there are many kinds of these facilities. The one that is emerging as, I guess I would use the term best in class, is a facility that might be described as a freestanding, non-hospital based psychiatric emergency room, ideally with an open clinic attached to it, where people can come in for observation and acute stabilization and intensive efforts to arrange follow-up care. And these facilities are also quite effective in resolving crises without having to go to the highest level of care, which of course would be acute inpatient hospitalization. So the ideal system would have those elements: the crisis care coordination or care traffic control, mobile crisis teams, and crisis facilities. And SAMHSA has just published or posted a set of national crisis guidelines that I think you'll find if you just search for SAMHSA crisis guidelines that lay all this out in detail.
So how often is this happening across the country where this sort of model is not only in place but is robust enough? Because it sounds like when it's working well, the crisis system can really handle most of the cases that come its way without having to resort to those higher level of care. But a lot of people probably have a feeling that in the communities where they are, that they may not have that robust crisis response. So what is the landscape like out there in terms of meeting some of these best practices?
Well, you've put your finger on the problem, because most communities don't have this. Most communities have a few mobile teams, or they, sort of everywhere in the United States is covered by a suicide prevention Lifeline center. But a lot of times those phone calls have to be answered in the next state because there isn't adequate capacity. And there are a wide range of crisis facilities, but the type that I described, that has the ability to do very high acuity triage and assessment and intervention is quite rare. There are probably more crisis residential facilities that might be described as respite facilities, not quite the same level of acuity, often without on-site psychiatry, and maybe with less psychiatric nursing presence than would be required in a higher acuity facility. So what's available around the country is quite variable. And a lot of that is because until recently, with SAMHSA's renewed emphasis on crisis care, and I would really want to credit in that regard both Dr. McCants Katz at SAMHSA, but also, and in particular, Dr. Anita Everett, former medical director, but now the head of the Center for Mental Health Services. Anita has really, in a sense, taken all this under her wing and helped to grow it. But setting aside that relatively recent interest, for many years, I would say going all the way back to 1980, when President Reagan essentially wrote the Community Mental Health Centers Act of President Kennedy out of the law in a budget reconciliation piece of legislation. There's been no national statute or funding or point leadership on developing crisis services. There was in the Community Mental Health Centers Act because emergency services were one of the 5 essential services of community mental health centers. But when that program essentially ended, there was no federal leadership. And so what we saw around the country was communities that had a good mental health center and developed good crisis services may have kept them going, although reimbursement would be challenging. Also, I tend to see a pattern whereby mid-sized counties or cities with, say, a population somewhere in the range of 250,000 up to 1 million, often have better developed crisis programs than large urban centers where the system is so complex and sometimes hospital-based that crisis services haven't developed. And also in rural areas where the economics of crisis care make it difficult to sustain an adequate program. So, if
Mike,
yes.
I wanted to just make a point. It sounds like we're moving toward a policy level discussion, which I love this kind of this notion of these 2 buckets of important element. But before we do, I just wanted to say that I really appreciated in your description of the three elements, how you wrapped in the notion of evidence and that this isn't just people making stuff up, right? This is, these components and these dimensions have been shown to work. And so this, and I feel like that's just not something that we should just take for granted. And I think it's really important, and I appreciate how you have sort of organized kind of your mission around sort of the ongoing gaps between what we know and what we do. But I just wanted to make that point because you kind of wrapped it into the discussion of the three elements, and I thought that was really important.
Well, thank you, Lisa, for calling that out, because it is, we shouldn't be working on solutions that don't have an evidentiary base, and I view that broadly, because unfortunately, with the funding for research being too limited, and expectations for research being tilted these days toward basic neuroscience, often there isn't enough evidence to solve practical problems. That was certainly a challenge that I faced in many years of trying to run states. Many times you couldn't find evidence to answer the big questions that were, in a sense, knocking at the front door. I do want to call out, in that sense, the leadership of Josh Gordon at NIMH, who's made it clear that he expects the fundamental mission of NIMH to be basic science, on the one hand. On the other hand, he's also made a commitment to have NIMH work where it could on urgent public health problems where the clinical needs are so great and all the evidence may not be yet available. And the best example of that is suicide prevention. So the NIMH's efforts to beef up that portfolio and to emphasize a practical research under Josh's leadership and also Jane Pearson's have really been helpful. And so the NIMH is a participant in this, in one of the leadership organizations in the Action Alliance. So the point about working off the evidence, and also I would say working off the voices of people with lived experience, those two sources are pretty critical.
As a segue, I was going to say that this is one of the recommendations that you make to as to what policy changes need to happen in order to improve the crisis system in the country. And a lot of the paper, I think, is arguing for a stronger federal role. So I thought it would be a good opportunity to go into some of the recommendations that the paper makes to improve the system, besides one of which is increased funding. But maybe you could walk us through a couple of the other ones as well.
Right. So I think the key need from the federal government around crisis care is leadership. And as I said before, with Doctors McCants-Katz and Everett, we've started to see that kind of leadership. We've also seen it with the suicide prevention branch at SAMHSA under Richard McKeon, who, before he became a Fed and a bureaucrat, worked in a community mental health center in New Jersey with an active crisis program. And so Richard was able to see and help shape the impact of a crisis program, both on suicide prevention and on finding the appropriate care for people. But the effort to provide federal leadership has to some extent been undermanned. It wasn't until very recently that SAMHSA had any statutory authorization to work on crisis care. And I think, I'm not 100% sure about this, I think that authorization might have been provided as one of the tasks given to SAMHSA under the 21st Century Cures Act. But in any case, it's a relatively recent development. And the authorization of funds to go with that leadership role was the princely sum of $10 million. So obviously we have a way to go. But one of the other things that has been developing that is very timely in a policy sense is that the nation's awareness of the problem of suicide has been growing, as the suicide rate itself has accelerated. The original national strategy for suicide prevention was one of those things advanced under Dr. David Satcher's leadership, with the development of the publication of an initial national strategy in 2001. So the good news is it was a national strategy. The bad news is the knowledge base was really limited, and the recommendations of that national strategy were somewhat scattershot. So the national strategy was updated in 2012, but it's only been, I would say, in the last 10 years that most of the relevant knowledge about suicide prevention has been published. And so, for example, the Barbara Stanley and Greg Brown's safety plan is now becoming ubiquitous, but we didn't have a controlled trial of safety planning published until the report of their big study in Veterans Administration emergency departments, which was published in 2018. Similarly, the suicide prevention field has to some extent been its own worst enemy by having people argue that since we can't predict who's going to die by suicide when, that screening is folly. And Dr. Greg Simon's article with a lot of co-investigators looking at utilization of the PHQ-9 in the Kaiser and other large health plan systems showed that the striking majority of people who died by suicide who had responded earlier to a PHQ-9 had in fact indicated thoughts of suicide in their response to question 9, so that in fact the predictive value, not of predicting death, which is kind of ghoulish, but of predicting the need for help for suicide, is very solid. It's superior to a cholesterol score for predicting a heart attack, and it's as good as high blood pressure is for predicting subsequent health problems. And it requires asking one or two questions. And so now we have evidence for screening, and we have evidence for brief interventions, including safety planning with means restriction, and also for what are called caring contacts, just brief follow-up contacts that are supportive and make a human contact with individuals, are very powerful in preventing suicide. So the evidence is really starting to emerge, but most of that evidence is relatively recent. And meanwhile, of course, since we haven't put enough of that into play yet in terms of providing really good protocols for suicide care in healthcare organizations, and because of circumstances in society and who knows what else, the suicide rate has increased by well over 30% since 2001, the original national strategy. Now, just this last week, we had the good news that for the first time in many years, there was a small reduction in the nation's suicide rate in 2019. So who knows what that is due to, but the rate has gone up, and it really remains unacceptable. And all of that has led to the focus on trying to improve the suicide prevention lifeline. So this is 1-800-273-TALK, TALK, and it's managed by a vibrant organization in New York under contract with SAMHSA. But the calls are answered through a network of 170 crisis call centers around the country, which essentially are not federally funded. They get a very modest stipend, but they're funded by state and local grants and bake sales. And
thus the need for more policy and financing and resources, to be applied in crisis intervention and suicide prevention.
That's exactly right. And so this is also, we're now seeing an example of local policy making it to the state level, because federal legislators in Utah, including former Senator Orrin Hatch, came to learn about the effectiveness of crisis call centers in Oregon, and began agitating in the Congress on this, which led to a project at the Federal Communications Commission to take a look at the feasibility of having a system for brain care, something like the 911 system for heart care and for other emergencies. So their legislation asked the FCC to take a look at that, and the FCC with SAMHSA and the VA took a look at our nation's call center system. And just earlier this year, in July, as a matter of fact, the FCC came out with a regulatory order directing all the phone companies in the United States to gear up to have a single 3-digit number that's going to be 988 for suicide prevention and for mental health crisis calls, and to have the arrangements for this in place by July of 2022. So we've got 2 years for this. So that's national policy that's starting to move quite fast. And
how well is non-suicidal crisis incorporated into the work that's already been done on the 988 line?
That's a really good question, and the answer is not very much, because as we've said before, we don't have much of a crisis care infrastructure, and so mental health crisis calls, go all over the map. The best estimates are there are these days about 2.5 million calls annually to the suicide prevention Lifeline. But the best estimate is that there are at least 4 times that many calls that are mental health crisis calls that go to 911.
Mm.
And there are lots of local crisis lines, and sometimes 211 is used for this purposes. And so it's a real patchwork quilt with no national consistency.
And the idea, though, is that 988 will handle everything in terms of mental health crises, both suicide and other mental health crises. So I imagine that's going to be a tough nut to crack in 2 years, both in terms of the infrastructure, but also some of the other recommendations of the paper are about not just building the call center, but about building the infrastructure for those times when the crises can't be handled over the phone, when there actually has to be somewhere to refer to.
Exactly, because so we have to have we need to have care, not just calls, is one of the ways that I describe this. And so now, but we've at a policy level, we started to move on that, because following the FCC's regulatory decision, Congress again got involved and passed legislation in both the House and the Senate that was just signed into law by the president earlier this month. And that legislation is called, if I remember it rightly, the National Suicide Prevention Hotline Designation Act. So Suicide Prevention Hotline Designation. This is a small piece of legislation that essentially concretized the FCC's judgment, but did several other things that I think are very helpful. It underlined the need for development of crisis care systems, as well as suicide prevention Lifeline initiatives. And following from what we've learned from 911, this act also gave states and other entities, local entities like tribes, but states in particular, the authority to enact modest cell phone charges to support both the call center functions, but also, and this is a real breakthrough, but also potentially to finance acute care alternatives. So if states act proactively on this, just as with 911, the tiny little surcharges on phone bills can go to cover the call system, but also to mobile crisis care and crisis facilities, the other elements of a comprehensive system. So this has moved very fast from a concept to a study to the FCC's decision, now to national legislation. There's a recommendation in that legislation also for an appropriation at SAMHSA to underwrite the Lifeline, but of course it's an authorization, not an appropriation. So we'll see where that goes in the budget process. But this cell phone charge thing is an even bigger deal. That's something that we didn't even anticipate. Matt and I didn't anticipate when we wrote our policy options. We weren't thinking that big.
So I think that the paper does a good job of laying out some other specific policy steps. If you were thinking big or bigger, I mean, I think these are big changes that you're talking about. What would be kind of something that was all-encompassing or could really be a game changer in the crisis services world?
Well, you asked the question before, and I'll go back to it of, how are we doing in this country? And there are really almost no places where all of these crisis care elements are in place with adequate capacity. Frankly, the only place that comes close on a statewide basis is the state of Arizona, which has got on a regional basis care traffic control systems that can also, both can answer crisis calls, but also can deploy mobile crisis teams with geomapping and tracking, and also have access to acute care crisis facilities. And so the one-liner for me would be to have every state in the country have all mental health and suicide crisis calls answered in-state, in places that can also, as Anita Everett puts it, send somebody to you if talking to somebody isn't enough. And finally, a place for you to go if you need more than a face-to-face conversation. And so the dream would be to have this in place in every state. Many states have got different pieces of this in place. For example, Georgia has developed over the years a statewide Georgia Crisis and Access Line that is a statewide call center for both suicide prevention and crisis calls with pretty good mobile capacity across that state. Colorado's got a great crisis response call center, but it's not really adequately connected to mobile crisis resources and to crisis facilities. So having that capacity in every state would be the dream.
So, Dr. Hogan, as we're talking about all of these issues, I wonder if you could speak a little bit about how these issues tie in with some of the broader conversations that we've been having really as a nation around race and policing. I think that that's obviously a key part of that, and I'm just wondering how you've thought about that tying into some of the things that we've been discussing today.
Well, it's a big question, and from my perspective, there are two very different lenses to look at mental health care and racism, or on the other hand, cultural competence. And one of those has to do with the dimensions of mental health services. Are they responsive and receptive to different needs of people of color, people who are poor? We have a lot of evidence that African-American men, for example, are overdiagnosed with psychotic illness and more serious, quote unquote, serious diagnoses, and perhaps overprescribed or more highly prescribed, more intense medications. And so within mental health services, we can respond by essentially an approach of cultural humility and cultural competence. But the second dimension, which I actually believe is larger, has to do with the role of mental health services within society. And there we see that there have been major issues with people of color and people who are poor being swept into the criminal justice system at alarmingly high rates. And that's where more responsive crisis services make a difference, because intervening when people are in crisis to offer treatment instead of incarceration is a fundamental shift. And that approach has not received enough attention. Sam Cochran's crisis intervention team approach, as he originally conceived it, involved a bargain, in effect, where police departments would provide specialized training and specialized teams to work with people who might have been mentally ill on the streets. And second, mental health systems would agree to accept rapidly into care people who CIT officers brought to them. In too many communities, crisis intervention has just meant the police change their training and do specialized teams, and the mental health system doesn't respond very much. So the component of modern crisis care that really is transformative in this sense is when crisis services accept directly from police people who are brought in without having to be booked, without going through civil commitment, without having to go to an emergency department, but direct acceptance of people into care. And it seems to me that that approach is the most profound approach to rebalancing our services that a modern approach to crisis care offers.
Do you think that this has entered the zeitgeist with the protests over the summer and calls for police reform or defunding the police?
Well, I would say it's in the early stages of bubbling into practice. There's been recent conversation about the Oregon approach, which involves a mobile crisis team that can respond to people in the community instead of, I believe, or perhaps collaboratively with police officers. And in fact, Senator Ron Wyden has introduced a bill that would propose to expand that model. So there's a recognition there that this can be significant. There are a number of crisis programs that offer alternatives in addition to this. One is a move to intercept or redirect calls that might historically have gone to 911 through a shared call center or through an approach which promotes use of a mental health crisis line instead of 911. The best estimates are that 10% of all 911 calls are actually for mental health crisis. And when the call goes to 911, there's a good chance that the police are the responders, and there's a good chance that not having alternatives like mobile crisis or crisis facilities, people may end up getting booked. So this is what I would describe as a significant but still emergent issue. And we've got to have all aspects of the crisis continuum in place to be able to really most appropriately redirect people from incarceration to care.
You know, and I really want to second that. And your work and the recommendations and the focused thinking about this are very, very important if we're really going to address structural racism and social injustice in our system.
Are you optimistic that things are going to, this is the time that things are going to get better?
Well, for some reason, I get in my mind I'm getting a flashback to a lecture that John Strauss at Yale used to give about a recovery. And after doing much more basic research for many years, John sort of turned to studying this phenomenon largely through conversation with patients. And one of his conclusions was that although recovery was an individual process for different people, that there were patterns to the process. And one of the patterns that he described was what he would call a low turning point. And that is where things had just gotten so bad that people would resolve to just do and be different in the hopes of better outcomes. So I guess in a sense, we've reached a low turning point and we started to come out of it with this extraordinary national legislation. But we still have an under-resourced system. There are complicated questions about how to pay for all this because cell phone chargers are not going to do it. Medicaid obviously is crucial, and Medicaid is paying for many parts of this in many parts of the country. But most people aren't on Medicaid. The whole question of how, for example, health plans contribute to this is really crucial. It seems to me, for example, that just as with ambulances, somebody comes up with money to buy the ambulance and build a garage, and then the cost of the run can be billed to various insurance providers. So we're going to need an approach, something like that. So all payers are going to have to be involved in supporting this, and payment is very fragmented. But I guess I'm optimistic because we have a path that will give us a productive road to follow for the next few years. And I think it's worth noting that 911 has been around for 50 years. So our national overall crisis system didn't develop overnight. I hope it doesn't take us 50 years, but I think we can really learn from 911 and how it's transformed acute management of cardiac distress, for example. So if we can get to the same place with respect to brain crises as we are with respect to heart crises, that would be a good thing.
That's a great message.
Yeah, maybe we'll end there on the realistic but optimistic note, and we hope it doesn't take 50 years also. So thank you so much for coming on, and we definitely encourage everyone to take a look at the article, and we really appreciate the conversation and all of the years and years of work that you've been putting into these really knotty and complex issues.
Well, thanks so much. Thanks, Josh, for orchestrating it. And Lisa, thank you for the invitation. I'm so glad you're doing this.
We're delighted to have you. The article really is a great roadmap, and it shows off the Think Bigger, Do Good series that I mentioned at the beginning of the episode, which is sponsoring these papers. So thank you.
Well, it's just it's a really great thing that you have partnered with Howard Goldman, who edits that series, to review these papers for psych services as well. So hopefully that's been good for the journal. It's been huge, I think, for the foundations that have made a small investment in this. So thanks very much.
Dr. Mike Hogan, thanks again.
Well, I'm sure you can see now why I admire Dr. Hogan so much, and he's been such an inspiration to me in my career. We invite you to visit our website, ps.psychiatryonline.org, to read the article we discussed in this episode, as well as other great research. We welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berzin.
Thank you for listening. We'll talk to you next time.